Assalamu alaikum and welcome everyone. I am Dr. Asma Ali and today we are breaking down one of the most important updates in reproductive medicine, the NICE 2026 Infertility Guideline. We will focus on evidence-based updates, a patient-centered approach and the key shift you must not miss in 2026. So let's get started and simplify the topic of infertility in the smart way. Now, the question is, why does this matter? Because this is exactly what examiners are asking right now. Outdated knowledge, you lose marks. Updated guidelines, you stand out. For FCPS and MRCOG Part 2 and 3, this is a hot topic. Expect it in your upcoming Viva, OSCEs, talks, or even a full station. And it's not just about exams. This is what defines safe, modern, evidence-based patient care. So if you want to score high and practice right, you cannot afford to miss this lecture. One subtle but important update in the NICE 2026 guideline is inclusive language. The guideline now explicitly includes trans men, trans women and non-binary individuals in fertility care. Now from an exam point of view, this is not a heavily tested area, but it is very important Viva point. If asked, you should demonstrate that your approach is respectful, inclusive and patient-centered. So even if it's not a major scoring topic, it can definitely help you impress the examiner. According to NICE 2026, infertility is defined as failure to conceive after 1 year of regular, unprotected vaginal intercourse in the absence of any known or suspected cause. And notice the updated wording. It includes women, trans men and non-binary individual with female reproductive organs. The key action point here is after 1 year, you should offer both the partners full clinical assessment and investigations. This is a classic exam question. They may ask for the definition directly or test when to start evaluation. So remember, 1 year is equal to investigate both the partners. Now this slide shows the common suspected or known clinical causes of infertility based on history, symptoms and signs, including both female and male factors. So have a look on this table. This is another important NICE update regarding artificial insemination. If a patient is trying to conceive using artificial insemination, you should not wait for full 1 year. Instead, if pregnancy has not occurred after 6 cycles, then you should proceed with further clinical assessment and investigation, provided there is no known cause of infertility. So remember this exam point. Artificial insemination is equal to 6 cycles and then investigate. Now this is very important age-based recommendation. If the patient is 36 years or older and trying to conceive, you should not wait. Offer immediate referral for specialist consultation. So the key message in this slide is age 36 or more, direct referral, no delay. This slide summarizes everything we have discussed so far, and a very important new update to remember is the fertility clock does not reset. Look, it is written clearly that no reset rule. So what does this mean? It means even if a miscarriage or ectopic pregnancy occurs, You continue counting the same timeline. You do not start the 1-year period again. This is a key exam point and a common area where candidates can make mistake in the upcoming exam from now onwards. So please try to grab this concept right from here. Now, this is where most candidates get confused, as I just mentioned, and where you can actually score as well if your concepts are clear crystal. When I first read this no reset rule, it did not fully click into my mind. I was confused until I started thinking in real exam scenarios. So in the next few slides, I will show you high yield exam style example that will make this concept crystal clear. And once you get this, you will not forget it in exam and you are going to get full marks. Let's take a classic FCPS Viva scenario. A woman has been trying to conceive for 10 months. She conceived, but unfortunately has a miscarriage at 8 weeks. Now the key question is, what should you do next? Old thinking was to start the counting again from 0, but according to NICE 2026, that is incorrect. You continue from 10 months, you do not reset the clock. So after 2 more months, completing 12 months in total, you should start infertility investigations. This is exactly how the new guideline should be applied in exam. Now, let's look at a very common exam trap. Another example. A woman has been trying to conceive for full 1 year, so she already qualifies for infertility workup. Just before evaluation, she got the good news that she conceived, but unfortunately, she ended up in a miscarriage. Now what should you do? Many candidates would think, wait another 1 year, but this is wrong. She has already completed 1 year, and as per NICE 2026, the clock does not reset. Clock continue tick, tick and tick. It does not wait for anyone. So the correct step is start infertility assessment immediately. This is a classic trap. Don't fall into it in the exam. Let's apply the same concept to the artificial insemination. A patient is undergoing IUI and has already completed 4 cycles. She conceived, but unfortunately, it turned out to be an ectopic pregnancy. Now what should you do? A common mistake is to restart from cycle 1, but again, this is incorrect. NICE 2026, you continue the count. She has already completed 4 cycles. So she needs only 2 more cycles to reach the total of 6. After which you should start further investigations. So remember, whether natural conception or IUI, the clock never resets. Now these are very high yield testing changes in NICE 2026 Infertility Guideline, and examiners love this area. Several tests are now removed or discouraged. For example, sperm DNA fragmentation testing is not recommended anymore. AMH not for predicting the natural fertility. FSH not for ovarian reserve in ART. And routine testing of serum prolactin and thyroid is not usually done. It is only if indicated. This point was clearly emphasized in the current guideline. So the key example is we are moving from over-testing to targeted testing only. This shift is very important, both for exams and real clinical practice.
This is where NICE 2026 gets interesting. What's newly added? First, genetic testing in males has been expanded, including Y chromosomes microdeletions, CFTR mutations, and karyotyping. And here's a very important new addition: celiac disease testing in cases of unexplained infertility. This is classic MCQ trap. Many candidates can miss this, so lock this in your mind that celiac testing is new update in NICE 2026. These are small changes but very high yield for exams. Now let's talk about treatment changes. This is very exam relevant. Some commonly used treatments are now no longer recommended. Ovarian stimulation alone in unexplained infertility is not advised anymore. Androgens for male infertility has got no role. And even antioxidants for sperm DNA damage is not recommended anymore. So the message is clear: avoid ineffective treatments. We have to stick to evidence-based care. What's new and updated in the treatment? For males, gonadotropins are only for hypogonadotrophic hypogonadism, and varicocele treatment can be considered in selected cases. For females, cabergoline is clearly recommended for hyperprolactinemia, and very importantly, hydrosalpinx must be treated before IVF. So again, NICE 2026 emphasizes targeted indication-based treatment and not on routine or blanket therapy. Now, this is a big shift in this updated guideline and very hot exam area. Previously, many patients were moved early to IVF, but now the approach has totally changed. IUI gets a much stronger role before IVF. You can offer up to 4 cycles of stimulated IUI before considering IVF, especially in unexplained infertility and mild male factor or mild endometriosis. This is a key exam change and a very common place where candidate can make mistake and can lose marks. So remember, IUI is first and IVF is later, not the other way around. Now have a look at IVF criteria update. This is another important exam area. IVF should be considered after 2 years of trying or after 12 cycles of artificial insemination. Age criteria remains important. Women should be under 42 years, and remember, under 40 years up to 3 cycles of IVF are recommended. This concept is now more clearly defined. So in exam, always think 2 years or 12 cycles, then IVF. Finally, some small but important lifestyle updates in this guideline. There is renewed focus on alcohol advice and detailed drug history, especially medications like GLP-1 analogs and testosterone, some kind of recreational drugs. And importantly, caffeine still shows no strong link with infertility, but this point is now re-emphasized in this guideline. These may look like minor update, but in exam, these are the details that can make the difference. This flowchart summarizes the complete infertility pathway from initial assessment to management. Start with the history and risk factor, investigate early if indicated, and then manage based on the cause, including IUI or IVF where appropriate. I won't go into detail here, you can quickly review this slide yourself. This flowchart shows the management pathway for artificial insemination. Assess and treat the underlying cause first, and if no conception occur after 6 cycles, then move forward accordingly, including consideration of IVF. You can go through the details on the slide for better understanding. This slide summarizes management of specific infertility causes. The key idea is simple. Identify the cause, manage accordingly, and refer early when needed, especially in age 36 or more or many other complex cases. The detailed pathways are shown here. You can review them quickly. Okay, alright, if you remember only a few things from this guideline, make it these top 5 MCQ tested changes. Number 1, sperm DNA fragmentation is not recommended. Number 2, AMH, not for natural fertility prediction. Number 3, miscarriages does not reset the infertility clock. Major exam point is this. Number 4, celiac screening, a new addition. And number 5, IUI before IVF up to 4 cycles. Lock these in. These are guaranteed exam hitters. Now I want to hear from you. What do you want next? MCQs from this guideline or a case-based discussion? Drop your choice in the comment box below and I will create the next lecture based on your responses. So let's learn together and see you in the comments. If you found this lecture helpful, don't forget to like, subscribe and support the channel. And most importantly, share this with your friends and colleagues because spreading knowledge is always a good idea. So thanks for watching and see you in the next lecture. Till then, bye.